And I haven't posted any of the reproductive system ones to YouTube yet. So hopefully people, not you guys, you're fine. You're all more than appropriate, but I mean random people. Hopefully random YouTube people don't ruin the fun for everybody by making lewd comments. So hello, if you're not my student and you're watching this and you're tempted to make a lewd comment, kindly do not. Thanks. All right, so male reproductive system. Remember, I'm talking about anatomic and gametic male in most cases post the average course of phenotypic development, nothing to do with gender. So what I'm really saying is, hey, if you developed a penis and testes with the spermatic cord and the whole nine, I'm talking about you. So this is the sagittal pelvic section of such. As we can see, the urinary system develops, the cloaca becomes a urethra, prostate gland, and fully mature bladder. Interestingly, the most direct route from the tip of the glans penis to the testis would be something like this. That is not how it goes, not at all. So the testes do this elaborate descent. Remember, I said orchid means testes, and cryptorchidism means hidden testis, which is a fun sounding word for a problem that's not all that fun. So the testes have to go on a long journey to get down into the scrotum. It's an important journey because sperm are individually weak and they are very, very sensitive to temperature. So they hang out in this sac of skin so that the cremaster muscle and the dartos muscle can adjust testicular height and tautness to thermoregulate the testes. In order to do that, though, they have to extend through the inguinal canal along with the spermatic cord, which is not fully pictured here. It includes the ductus deferens, but it also includes a bunch of cool arteries and veins, more on those later, as well as nerve structures, lymphatic vessels, etc. So there's a bunch in there. But regardless, they have to pop out through a hole in the anterior body wall. And because there is a hole and therefore a weak patch there, that predisposes people with this anatomy to inguinal hernias at much higher rates. And that is where the Valsalva maneuver, so changing intra-abdominal pressure due to things like lifting heavy stuff, pushes a loop of bowel through the hole and often pushes it sort of down towards the testis. Yeah, so they're pretty common, especially in, I don't know how old your dad is, but like middle-aged to older males, as the body wall sort of weakens with age, if it's, you know, not necessarily maintained bodybuilder style. But anyone can theoretically get one. It's just that if you had testis that descended, you're more likely to. So if you lift with a weight belt and make sure that you are maintaining your core. That's the best way to sort of prevent those things. Also, try and lift with your legs if possible. Don't lift with your back, and, you know, just be safe about it. So as you can see, the erectile tissues of the penis are kind of suspended via a ligament here from the pubic symphysis. And the penis exteriorly, the part that you can see and that's covered in skin, is quite a bit shorter than the full length, which goes all the way back to the root of the penis, which is pretty close to the perineum and the anus. And then the testis and the epididymis are suspended below in the scrotum. The vas deferens does this elaborate loop-de-loop going up over the pubic symphysis, over the bladder, it crosses over the ureter, and then it plugs into the back of the prostate at the ejaculatory duct. So quite a distance. And guess what? Sperm don't swim that distance. More on that later. My fiance and I were talking about this stuff because I teach reproductive stuff several times a year, and I'm always amazed at the extent to which some subpopulations of my students don't know very much about their own anatomy, probably because of abstinence-only education and lack of sex education in the United States. But he remarked, he was like, I think you probably know more about the male reproductive system than most people with that anatomy. What's that like? And I was like, I don't know. It's an occupational hazard, I suppose. It doesn't seem that weird to me. But if I had all this stuff, I would want to know about it. And so here we go. The testes are fascinating. The ovary is also fascinating. That's not what we're talking about right now. So basically, they're a bunch of wadded up tubes. And the tubes consistently produce spermatozoa meiotically from puberty until death. Now, that's not to say that the quality of the germ cells produced is excellent all the way through. It's absolutely not. But due to the presence of spermatogonia, more on those later, there is consistent sperm production for the comparatively lengthy reproductive period of people with testes. That's a major difference between people with testes and people with ovaries, which is why I mention it in advance. So the anterior cover, and note that the head and the tail of the epididymis, giving rise to the vas deferens, are posterior. The tunica vaginalis is anterior, so you can see it. And like most things with two linings, this has a parietal layer and a visceral layer. So the parietal layer is the one that faces away from the space, and the visceral layer is on top of the front of the epididymis and the testis. Underneath that is the tunica albuginea. Vaginalis, by the way, if you're looking at that and you're like, that looks like vagina, why? Invagination is just a name for an infolding of something. So the organ, the vagina, is named after that. But anything that invaginates, like this thing, is named the blah, blah, blah vaginalis. So that term is not limited to being utilized for female reproductive structures only, not by any means. Tunica albuginea means white layer. So why is it albuginea? Well, it's actually really white. When you dissect the testis out of the scrotum, it's stunningly white. It matches its name very well. It looks like a shiny egg. That dips in between the tubules, forming septa, which basically just package the seminiferous tubule into orderly lobules and provides a space for the anchoring of blood vessels and other things. Between the tubules are Leydig cells. They're often kind of smushed into triangular arrangements because they are between like three tubes. And these produce testosterone. They produce testosterone in response to stimulation by luteinizing hormone from the anterior pituitary, since we just did the endocrine system. Sustentacular cells, or Sertoli cells, these are found within the testis, and they actually line the entire length of the tube like pages in a book. So they're narrow, and they have one edge that adheres to the tube, like the side of a page that binds to the book binding. And then the other edge flaps free. And then there's many, many, many of them in a row along the tube. And the germ cells develop sandwiched between them. So they do a variety of things, including release cytokines that regulate the rate and productiveness of sperm production. They promote their development. They also help make sure that sperm cells that might be not so great in quality, maybe they did some synapsis and crossing over incorrectly, and there's some, aneuploidy going on. They can correct for that as well by inducing autophagy in genetically wrong sperm. Not always, but sometimes. And they also maintain the blood testis barrier, which protects meiotically different germ cells from being noticed by the immune system. Because if they were, natural killer cells would be like, aha, a tumor, kill it with fire, or tumor necrosis factor, as the case may be. But there is a blood testis barrier. And then germ cells include, and By the way, we're going to look more closely at this because this picture is tiny. So don't, if you're like straining your little eyes, being like, how the hell do you tell that that's a spermatogonia or a spermatogonium? Don't worry. Regardless, though, the germ cells include spermatogonia, spermatocytes, and spermatids. And then by the time they're done developing, they've got a tail, and their tail is sort of poking into the lumen, and they're about to be released. And then we call them spermatozoa. So A and B are the connective tissue coverings that cover over the seminiferous tubules. And we've got lots and lots of interstitial cells that secrete androgens. We can see here interstitial cell, interstitial cell. Remember, interstitial cell and cell of Leydig, these terms are synonymous. So Leydig is the guy that discovered them. Interstitial refers to their name based on their position, basically. As you can see, if you look at picture B, interstitial cells have a foamy appearing lumen. Again, that's because they're making androgen, and androgen is a steroid hormone. So it's not miscible with water or stain, which means that it manifests as these little light spots. See? Alrighty. So C and D are immunohistochemistry against Sertoli cells specifically, meaning support or sustentacular cells. And you can see that they are localized inside of the seminiferous tubules. So earlier I mentioned sort of quality control of the developing spermatocytes. So like with any tissue that's highly regenerative, or in this case, just generative, the more times you divide statistically, the more likely it is for an error to occur. So there is an inherent risk in creating sperm. Fortunately, although 95% of testicular cancers are germ cell tumors, and that's usually because the interstitial cells and the Sertoli cells divide infrequently, even those are relatively uncommon, again, because the Sertoli cells do pretty good quality control. They are much more likely to develop in people with, and there's a piece of antiquated terminology, so pardon that, I'll fix that. You might have noticed for SL6, I changed it from gender physiology to something like physiology of reproductive structures, scientific literature works. So I'm going through and finding them here and there, but I think it's important to acknowledge when there are little mistakes like that. So I don't mean men. What I do mean is people with testes, and in this case, people with testes who have not descended for whatever reason. Okay, so if you were listening to me talk about the nurse cells slash sustentacular cells, and you were like, what does she mean by book pages? Here's another view of that. So we've got the cell's basement membrane down here, and then this is one cell. So here's its nucleus, and then here's all of its cytoplasm, and then here's its neighbors. And if you were to go forward into the screen and backward away from the screen, there would be many, many more layers of these things. So the spermatogonia that are dividing in the picture are dividing on top of the cells that you're seeing, and underneath cells of a different layer. So they're gently sandwiched between. So a spermatogonium is diploid, as evinced by the number 2n. So it undergoes a first round of division, and that round of division produces one additional spermatogonium and one primary spermatocyte. So Type B spermatogonium is the guy that differentiates into the primary spermatocyte, and that will divide into 2 secondary spermatocytes, dividing into a total of 4 spermatids. And note, these are spermatids. This is a bit of a misnomer. So we actually still call these spermatids because they have not yet been released into the lumen. Once they have, we call them spermatozoa, meaning sperm animal, but not before the process of spermiation, which is where the nurse cell releases the sperm from the tip of itself. So lots of sperm words here. Spermatogenesis is the process of making a sperm. That includes meiosis and shape changes. Spermiogenesis is the process by which the spermatid goes from looking like a weird little ball to looking like something that could swim. And then spermiation is the release into the lumen so that the spermatozoan can be carried off to the epididymis. Does anybody know who named spermatozoa spermatozoa? I'll give you a hint. You might have heard of him in early basic biology. John spermatozoa is not the right answer, but that was hilarious. It was actually Anton van Leeuwenhoek. Do you remember that guy? So he was, yep, microscope dude. So he invented the microscope a long time ago. I believe it was the 1500s. Don't quote me on that. So this is amazing. Also, fun fact about Van Leeuwenhoek. He was also the first person to do in vitro fertilization, but with frogs. He was very interested in sperm, all kinds of sperm. So he also named the cell. He looked at plant cells and noticed that they were like little weird rooms, and that's where monks live. So he was like, it's like the thing that monks live in, so I'm going to call it a cell. Et voila, the name cell was born, and I use it all the time. So he also was like, whoa, dad, plants are cool. I think I'm going to have sex with my wife and then look at what comes out of us. A very curious man this man was. So he did exactly that, or we can assume so based on his journals. He was religious, so there was certain no-nos about sex, so you're supposed to do it procreatively. So he had sex with his wife, looked at what came out, looked in the dish, and noticed that sperm were motile, meaning they were swimming around. So he was like, good Lord, they're moving. They must be animals. So I'll name them spermatozoa because that means sperm animal. And so that's why he named them that, because he was like, holy crap, they move. Whoa, dude. And then he went on to observe the same thing in amphibian sperm, and he collected frog eggs, and he was like, well, maybe if I put this near that, tadpoles. And turns out that that's what happened. So lots of sperm related scientific trailblazing with that one. I think you're correct. I think he did have some disagreements with Newton, but I don't remember the nature of them. But yeah, Van Leeuwenhoek was a real big deal, and for a lot of reasons. Also fun fact, when he started promoting his findings about how new animals might come into being, that was at odds with the current dominating theory of spontaneous generation. And so Van Leeuwenhoek, and then also later dudes like Spallanzani and then later Pasteur were the pioneers that helped disprove spontaneous generation. So the idea that you have to combine gametes to make a new individual, and that involves sex, versus like things springing into being from nothingness. So there's a little bit of sperm related scientific history for you. Oh, interesting. I'll have to watch that. Okay. The rete testis. That's how you pronounce this, rete. I've heard all kinds of creative pronunciations, and I'm guilty of them myself. It is not rete testis. It is rete testis. I know it's not very satisfying. So essentially, once the sperm are spermiated, they're going to flow into the rete testis. And from there, they will be moved into the efferent ductules and the epididymis. And it's important to note that they are not supposed to swim yet. The reason for that is that if we look at the anatomy of a spermatozoan, let's go back. They're extremely rudimentary cells. So they have very little cytoplasm. They have like this mid piece with this cool spiral of mitochondria, but they don't have any place to store a food vacuole or much glycogen. So as far as fuel utilization goes, they are as stripped down as it comes. So if they waste a bunch of energy swimming their way out, they're not going to have any when they get to a cervix, for example. And they certainly wouldn't be able to swim up a fallopian tube. So they have to conserve their energy. So they are kind of just pushed along at this point. So the testicular artery, this has relatively low oxygen, which means that the actual oxygen supply to the testes is not that great, not as much as you would expect. This makes the testicular artery and the deferential artery, which also follows the vas deferens, a little bit vulnerable. But it's important that it is the way it is because you're supposed to have not that much hot arterial blood going to the testis, which is to help thermoregulate the testis. Because again, sperm are very vulnerable to heat. They don't do well if it's warm. In the case of people with testes who are having a hard time conceiving, the doctor recommendation that's often made fun of, which is like, wear loose boxers, don't sit in the hot tub. Those are real. Basically, you want to keep the scrotum as far away from the body as possible and away from anything that would make it hot. So the testicular artery flows into the testes, and the blood returns via the pampiniform plexus, which is a braid-like network of oh yes, that's true too. Testes did indeed involve in a cold-blooded environment, so they work best. They do indeed work best at lower temperatures, which is why if you think about the taxonomy that you know, think about every animal you've ever seen that has very obvious testicles. So unspayed cats, unneutered dogs. It's about to be squirrel breeding season. Squirrel testes are going to become very obvious not too long from now. All of these have pendulous dangling testes. Have you ever seen a lizard or a snake with a pair of pendulous testicles? No, you have not. You know why? Well, they're inside because they can be, essentially. Interestingly, though, they are all on mammals, but among mammals, some of us have what's called testicular recrudescence, where the testes will ascend and descend and change in size seasonally if it's a strongly seasonal animal. And if it's not a strongly seasonal animal, they'll just kind of stay the same way all the time. So it really does depend. The relationship between the testicular artery and the pampiniform plexus, though, is very cool, and it's a neat adaptation. So this is a countercurrent heat exchanger. So let's just bring up EpicPen really quickly, and I'll draw you how this works. Yeah, I had male rats as pets growing up, and my mom could not stand them because she was very off-put by their external genitalia. I didn't mind, but she did. Okay, so real quick, just checking, because sometimes EpicPen doesn't cooperate. Can you see the white screen when I turn it on? because I can't see the chat when I do that. Okay, thank you. Appreciate it. All righty. So let's draw ourselves a testis. I guess I'll make it purple because reasons. Okay, so here we have our little testis. Epididymis first. There we go. I'm not going to draw the vas deferens because I'm lazy. And then we have the pampiniform plexus. And I'm just going to sort of draw it like a ladder-ish structure. So this is the direction. And we're not going to worry about oxygenation because that's not the important part here. We know that venous blood is low O2 and arterial blood is high O2. But heat conduction obeys the laws, the same laws as diffusion and other particular movement goes. So always goes from area of high heat to area of low heat. So I've drawn these artificially far away from each other, but in reality, the testicular artery is really, really close to the pampiniform plexus. And that means that radiant heat energy, which I'll make be orange, is going to go this way. So it naturally just flows passively into the pampiniform plexus veins, which is why the testicles are maintained at about 3 degrees lower than body temperature because of this passive heat movement. And all of that only works because of the way the vasculature is set up, and it's passive. So it's literally just a structural tweak that creates this lower temperature testis, which is awesome. All right, and then finally that blood testis barrier. Tight junctions between sustentacular cells, and I think they're actually illustrated. Yeah, here we go. So these are going to maintain the barrier between the blood supply and the testes themselves, and that prevents the immune cells from noticing that the gametes are different from the rest of the somatic cells, which would be a problem. Okay. So here we can see a nice transition zone, which you don't always get, but the seminiferous tubule drain into the straight tubules, which connect to the rete testis. And they're not especially numerous or obvious. They're just called straight because they're straight. But you can see a notable epithelial change at this juncture, where we go from having germ cells and sustentacular cells to abruptly having a ciliated epithelium. And that's going to help move the fluid along. There's also blood vessels between with connective tissue like everywhere. There is some simple cuboidal epithelium as well, but there are also, as you can see, cilia, which are important, and they become way more numerous as you approach the epididymis. All right, the mediastinum testis. This is this area here. And basically it's sort of this middle pinched region made of connective tissue that forms the septa, which you can see radiating away from it. So the seminiferous tubules connect to the straight tubules, none of which are particularly visible here, except for maybe that one. And then those dump into the rete testis, which goes to the epididymis. So as you can see, there's blood here. And as you can tell, even though the sperm is not swimming out, there's not any sort of direct door or prevention method between the seminiferous tubules, the rete testis, the epididymis, and the ductus deferens, which means that it's possible for bacteria to climb up the urethra, and instead of ending up in the bladder, have a little walk down the epididymis, or down, excuse me, the vas deferens, and end up in the epididymis or in the testis even. So the testicular duct inflammation is called orchitis. This can be caused by a UTI that decides to go look around. It can also be caused by chlamydia or Neisseria gonorrhoeae, aka gonorrhea. Interesting note about these two sexually transmitted infections. They are more common than you might think. Chlamydia in particular is kind of insidious because it's often asymptomatic, meaning people don't even know that they've got it. And that's the most dangerous kind of spreader of something because they are completely unaware. So this is why having safer and protected sex with someone whose medical history you're not familiar with is important, among other things. But also, due to advances in birth control that are not barrier methods, so we've got PrEP for HIV now. We have very advanced birth control that's much more effective than it once was. Among certain populations of people, mostly people who are just sexually active, there's no specific like cross section, there is an increase in medication resistant gonorrhea. So super gonorrhea that is antibiotic resistant and very bad. So just if you are out there, make sure that you are having protected or safer sex. My God. That you don't want the super gonorrhea. It's really bad. It's really scary. And you can also get it in other mucous membranes besides the reproductive tract. So yes, it's possible to get both chlamydia and gonorrhea in your pharynx, for example. So go with caution. And yes, that is part of why it's encouraged for people to pee after sex, making sure that to the greatest extent possible, anything that may have kind of snuck past the defenses into the urinary tract and might be on its way to the reproductive tract is just cleared out by a rush of acidic urine, which is honestly quite effective at killing things. Pee is pretty acidic. We put a lot of protons in there, and that is pretty good at having infection resistance. So persistent inflammation can actually lead to fibrosis of the ductal system. And that's a pretty common cause of, hold on. All right, sorry, sneeze. Pretty common cause of male infertility. So people think of male infertility as people producing, thank you, poor quality sperm, which is sometimes the case, but it's sometimes the fact that persistent inflammation and subsequent fibrosis just prevents the sperm from getting out. And then there's a comment in the chat that I think is worth acknowledging because geriatric medicine is rising in importance in our increasingly old society. STIs among elderly have definitely risen due to drugs like Viagra. So if you are one of my students or you are a random YouTube person watching my video trying to, learn things, I think it's important for everybody to understand that the elderly are having far more sexual intercourse than we think they are. And at least right now, 2021, a lot of the elderly that are doing so grew up at a time when sex education was very poor. So part of gerontology, especially gerontology of folks who are in nursing homes, does involve prevention of and treatment of bacterial and viral infections, sexually transmitted ones, in assisted living communities and geriatric patients. So that's just a fact. Everybody pretends like old people don't have sex, but they 100% do. So use protection regardless of age. All right, Epididymis. So the epididymis is interesting because it's arranged in a similar manner to the testis, which causes students to get the two mixed up. But it's really different looking. And I would recommend going on Histology Guide and just pulling up the two in two different tabs and looking at them side by side. That's going to be the greatest predictor of your lab success for differentiating between the two of them, is just being able to visually make note of the difference. So if this was a seminiferous tubule, you'd see cell nuclei from here all the way to the center. You don't. So we have pseudostratified columnar epithelium with very strong cell polarity. So the nuclei are really backed away from the apical surface. And then lots of cilia and this cluster of spermatozoa just chilling in here. Remember, they're not swimming yet. They are just hanging out. So the columnar epithelium is surrounded by a little bit of smooth muscle. And that smooth muscle is going to be there to, along with the cilia, sort of help the spermatozoa leave the epididymis. So again, no swimming, not yet. So the efferent ductules, remember, are the little, they're about 12 per side, ciliated ducts collecting sperm from the rete testis and transporting it to the epididymis. The epididymal duct actually is where the sperm mature and finalize, get ready to go. And they remain fertile for 40 to 60 days. The ductus deferens is basically going from the scrotum to the bladder. It's also called the vas deferens. You can use either, they're interchangeable. I don't care which you use. And if you're wondering, like, oh, but what happens to the sperm after the 40 to 60 days? Because obviously they're constantly being produced in response to gonadotropins. So then what if they don't, make it out? And the answer is they get eaten up by immune cells. So you do actually have an immune involvement in the sort of ridding of sperm that are not available for use, essentially. So the seminal vesicle is on the back of the bladder. So this is the posterior view, as you can see. And the seminal vesicle, in this side, it looks like it's continuous with the ureter. It's not. It's actually a glandular outgrowth from the cloacal structures that form the prostate and the bladder. And so that helps with semen production along with the prostate gland. So the seminiferous tube, the seminal vesicle is what I was trying to say. This produces a fructose-rich and vitamin C-rich sort of goopy substance, which is there to nourish the sperm. And it also contains prostaglandins and sort of activating chemicals. And then the prostate gland primarily produces alkaline fluid, which is going to help buffer the spermatozoa against the acidic environment of the vagina. And then there's also fibrinogen and seminal plasmin in there, which forms a clot. So yes, semen does clot, and there's a specific adaptation to that related to gravity and walking around upright. So we'll talk about that a little bit. I will talk about it more in the context of the female reproductive tract, though, because that's a better place to point it out. But it is fascinating. All of my A&P students are like, why is there fibrinogen in semen? That sounds gross. No, it's not gross. It's critical to fertility. So I'll explain. Okay, male infertility. Frequently idiopathic. Idiopathic is the fancy doctor way of saying we don't know why. Unknown etiology. But you sound a lot smarter if you say idiopathic instead of duh, I don't know. So doctors say idiopathic. Poor semen quality is one possible result or possible cause, and this could be anything from low sperm count to plenty of sperm, but they swim poorly. So ciliary genetic disorders tend to produce sperm that just don't swim. Abnormal sperm morphology and flagellar defects. So any of and all of these can be the cause. It's pretty difficult to suss out the root cause of male infertility. All right, ductus deferens. This is a thick tube It's often confused histologically with the ureter, but if you look at the epithelium is way different. And the ureter's smooth muscle wall is not as thick. So there's two ways to check the difference. What part is operated on for a vasectomy? This is why vasectomies are reversible. So essentially, a vasectomy happens where, since the ductus deferens or vas deferens goes up through the spermatic cord, it's essentially a small incision is made in the more proximal area of the scrotum. A small loop, not very much, of the ductus deferens is pulled out. It is snipped, ligated on each end. So just tied shut and or in some cases cauterized. And then poked back in, and then the little hole is sewn up. So that effectively prevents what's being made in here from getting to in here. And the reason they're reversible is because you can go back in, cut the two ligated ends, sew them together, and then if you have a good surgeon and they're good at things like making sure there's minimal scar tissue, sperm should be able to get back through after that. So most people get a vasectomy as an elective and permanent birth control method if they just don't ever plan on having children and they happen to have a penis and a vas deferens. However, some people do end up getting theirs reversed. So a common fear among people with a scrotum is, well, if I get a vasectomy, I will be permanently infertile irrevocably, and that's just not true. Especially these days. Also, vasectomy is a much, much less invasive procedure than a tubal ligation, which is, of course, where they go in and tie off the oviduct, which is deep, deep in the pelvis and very hard to get to. Yeah, unfortunately, in our country and society, procedures like that are considered elective and they are not covered by insurance, and they are often quite expensive. There are other cheaper options for people with that anatomy to sort of have similar surgeries like injectables and whatnot, but none of them are cleared by the FDA yet, unfortunately. Keep an eye out though. And again, if you're wondering, well, then how does the sperm get out? Because they're still being made, right? They just get eaten up by the immune system. So macrophages are like, well, you're not going anywhere. Might as well eat you. Fun fact about sperm quality, you can actually observe it microscopically using phase contrast microscopy to observe the behavior of live sperm. And it's pretty easy to tell if they're not doing what they're supposed to. So I remember looking at some, it wasn't human sperm, it was animal sperm in a dish one time for some research stuff. And one of our lab animals had sperm that like either didn't move, or if it did move, it went in a circle. So I just watched this one sperm go in like a loop for about 15 minutes until it died due to the heat of the light. That was pretty funny. Not going anywhere, that little guy. So back to our ductus deferens here. The reason that it looks different from the ureter, and I mentioned, right, that it has this really prominent layer of smooth muscle, which is very dense. The ureter has smooth muscle too, but it's intermixed with elastic and collagen fibers, and it's not especially robust. During the process of ejaculation and emission first, ejaculation second, the ductus deferens undergoes powerful peristalsis to move spermatozoa into the ejaculatory duct to be combined with the seminal secretions of the prostate and the seminal vesicle. So peristalsis is necessary for sperm to get out additionally. So the epithelium is pseudostratified. It's got lots of basal cells for replacement, and it's got some cells that are ciliated, again, helping that movement. And then we already talked about vasectomies. Okay, so we'll do this slide and then I will take a break because it's been an hour. Let's talk about semen. And I want to stress that I know that in colloquial English, sperm and semen are interchangeable words. They are not in science. So semen is a complex secretion with lots of different stuff in it. Sperm are spermatozoa. They are cells. So if the ejaculate consisted only of sperm, we would be SOL, because sperm by themselves, just a little spermatozoa on his own in the world, is a very vulnerable cell. They're highly specialized, but very fragile. So we have to provide spermatozoa on their journey to where they're supposed to go in the grand attempt to create a new individual. We have to combine them with stuff to help them. So that's what semen is all about. So the seminal vesicle produces the most of it. So there's fructose, which I mentioned previously, which is for energy. So that provides the numerous mitochondria of the sperm cell with food basically to use. Prostaglandins, which are inflammatory cytokines that stimulate female reproductive tract activity. And as I mentioned, fibrinogen. Remember, this is converted to fibrin and forms clots, but not blood clots, in this case, semen clots. So the prostate gland produces a milky secretion that's only about 30%. This does have bicarbonate in it. It also has prostaglandins as well as enzymes like lysozyme, which is an antibacterial enzyme, as well as seminal plasmin, which dissolves semen clots afterward. The bulbourethral gland, or Cowper's glands, these lubricate the glans penis, bam, right there, which is an expanded region at the end of the penis that is not present in all mammals. It's very prominent in Homo sapiens specifically. It's kind of a weird structure for us. It's theorized to be a structure that evolved to do sperm competition. So scrape out the semen of a previous partner because, you know, apes are promiscuous, but no one knows that for sure. It's just an interesting idea. But the bulbourethral glands, they're down here, and then they push this very thick, clear, alkaline mucus up through the penile urethra. And in addition to lubricating the intromission, which is the medical and scientific term for the insertion of a penis into a vagina, other important step, pee is super acidic. And spermatozoa are very vulnerable to acid. So we don't want any leftover urine in this tract, because then during ejaculation, we just have millions of sperm cells dying just in here because they would fry to death due to urinary acid. So we got to protect them from that. So that's the other function. Because of that, and because a small amount of semen or sperm is present in the bulbourethral secretions, people always ask this, so I figure I'll answer it. The answer is, although it is unlikely, it is absolutely possible to get pregnant from pre-ejaculate. It is not devoid of spermatozoa. It has some in there. Their survivorship and quality may be low, but theoretically it is possible. So, common misconception, now you know. So prostate cancer is the most common cancer in non-smoking men, and it mainly occurs in the peripheral, so edge zone of the prostate. Most common symptoms of it are, it takes a really long time to void the bladder. So you'll have an inappropriate sensation of needing to urinate, dribbling of urine, and when you do urinate, it takes forever. So anybody who observes those symptoms should go to a urologist and or urinary oncologist to get that checked out. Fortunately, it's also one of the most survivable forms of cancer for lots of people. So, you know, if one must get cancer, it's not the worst one to get, let's say. Okay, time for a break. And then when we come back, we will talk about penile histology and move on from there. So I will see you back here in about 3 or 4 minutes. Thank you. I'm glad to be back. Okay, so penis. This is also what's called the intromittent organ. So intromittent again means insertion of the penis into the vagina. In most reproductive science, of course, that's described on terms of reproductive attempts. But I think it's important to acknowledge, because we're all adults here, that human beings have sex for reasons other than reproduction. So just intromission, let's say. So 3 bodies of erectile tissue. So it's actually pretty complex. A lot of people just think of it as some kind of odd blood balloon, which it kind of is, but that's reductive. So previously I characterized a lot of systems, including the reproductive, as a sort of handshake between the nervous system and the endocrine system. And that is true here too. It's also a handshake between the parasympathetic and sympathetic nervous systems as well. So during the arousal phase, there's a combo package of sympathetic and parasympathetic and endocrine goings on. So if you were to measure somebody's plasma oxytocin and endorphin levels during the arousal phase, you would see them go up. So there's an endocrine component that increases smooth muscle tone in various reproductive structures. And as you might imagine, there's plenty of smooth muscle in the reproductive tract. And then the sympathetic and parasympathetic nervous systems cooperate as well. So like most glandular tissue, the seminal vesicle and prostate primarily respond to parasympathetic innervation. So they begin to make seminal components in response to parasympathetic stimulation. The sympathetic nervous system acts specifically on the penis. And this is a neurotransmitter that might surprise you. No, it is not norepinephrine. It is nitric oxide, NO. So nitric oxide is what's known as a gasotransmitter, so gaseous neurotransmitter. And nitric oxide is a very potent vasodilator. So it relaxes the smooth muscle of blood vessels, specifically the deep arteries of the erectile tissues. And that allows blood into all of these sinusoidal spaces, which fills up the 2 corpora cavernosa, these top bits, with blood. The corpus spongiosum also becomes erect, but not as much. And that's for a very good reason. If you look, the urethra passes through it. So turgidity is important. Turgidity is rigidness or hardness. Turgidity is important for intromission. It's a critical component of it. However, you don't want the corpus spongiosum to become so turgid that the urethra collapses and the sperm can't get out, because that's the whole point from a reproductive biology perspective. So this part does not become as rigid as the top 2 for a very specific reason, that reason. So the corpora cavernosa at the base of the penis diverge like arms. So they head back towards the root and then they go to either side of the pubic arch. So we call them arms or cru. And by the way, the deep clitoris has this exact same structure, so not that different. So it's full of lacunae, which are blood sinuses, and then the trabeculae are made of collagen and elastic fibers. So basically, during arousal, when nitric oxide is being released onto the deep arteries, it dilates them and lets more blood in than is able to escape due to the venous vasculature of the penis. And then once the arousal phase has concluded, typically post-ejaculation, the deep arteries go back to normal and blood gradually drains out of the penis, returning it to its flaccid and easily, more easily walk-aroundable state. So that is basically the physiology of erection. It's a very complex and interesting sort of dance of interactions between the sympathetic, parasympathetic, and the endocrine system to produce this transient effect on this very specific and specialized tissue. So the corpus spongiosum has the urethra in it. The two corpora cavernosa at the top have the lacunae and trabeculae, as well as each a deep artery or two. There's blood vessels. This is the tunica albuginea. So if that sounds familiar to you, because you're remembering it from the scrotum, you are correct. So again, tunica albuginea means white layer. And again, when you dissect a penis, it does appear white. This is critical because this is very dense collagen. And what it does is it causes the increase in blood in here to not be able to expand outwards. And that's what creates turgidity. So because fluid is incompressible, if you fill a finite but flexible space with fluid, the more fluid goes in there, the more rigid the structure becomes. And that's not only true of penises, but you would not be able to have an erection without both the blood-filled space and also the tunica albuginea. So you need both. So let's have a little closer look here. So again, we've got parasympathetic innervation, but there's also evidence that the nitric oxide comes directly from sympathetic nerves, which makes sense because the sympathetic nervous system is one of the main places where this type of nitroxidergic neuron is found. So this is a little bit outdated information. So essentially, we've got these little spaces filling up with blood. So here's the corpus spongiosum. There is smooth muscle in there as well. And then we've got a variety of urethral glands. So these are only going to be found in the corpus spongiosum, and that is because that's the home of the urethra, and you need to basically maintain the urethral mucosa with glands, and that releases secretions that are similar but not identical to the bulbourethral glands. So they tend to be not as viscous as those of the bulbourethral glands. So let's talk about erectile dysfunction, which is also sometimes called impotence, but ED is a more common piece of terminology now because impotence has sort of a qualitative negative connotation and erectile dysfunction is more structurally accurate, let's say. So it can result from diabetes because vascular changes are common with diabetes, vascular disease as well, and or nerve damage due to prostatectomy, but also due to anxiety. So I think we can all acknowledge that having sexual experiences for many human beings is not always, the most comfortable situation. People feel a lot of anxiety around sex, and that can produce changes to erectile tissue behavior, both for people with clitorises and for people with penises. So some of it is psychogenic, some of it is pathogenic. It really just depends. Drugs like Viagra can inhibit smooth muscle cells of the helicine arteries to cause them to relax at higher rates or be more ready to relax. And a lot of those drugs actually act on nitric oxide. So interesting fact about sildenafil citrate, Viagra, it was originally in clinical trials to be a hypertension drug because people thought, well, we know that nitric oxide does this thing to smooth muscle. So maybe if we inhibit nitric oxide's action on smooth muscle and its resulting sort of cyclic AMP based calmodulin based sort of contractile action, maybe we can relax smooth muscle in veins and arteries and lower hypertension globally. But during the clinical trial, participants in the trial were like, hey, yeah, so my blood pressure hasn't really changed except for in one place. And in that place, it's changed a lot. And that place is my penis. That's how they figured out that sildenafil was pretty much garbage as a global hypertension drug, but was very effective for treating erectile dysfunction. And so it was swiftly rebranded as an ED drug and came out on the market shortly after that. So the discovery of Viagra as an anti-ED drug is actually a straight up accident, not on purpose at all. And it just goes to show you that sometimes during clinical trials, you don't get what you expect, but it's still marketable. Who knew? Exactly. I guess big congratulations to Big Pharma for that oopsie daisy. All right, so again, a nice sort of, yeah, like Post-it notes. 3M. 3M is a company that's been fortunate enough to have a lot of happy accidents, let's say. All right, female reproductive system. Here we have an image of, oh, look, a fetus. And this is a specifically interesting fetal image because we can see the early fetal brain vesicles. So here's an early cerebellum, there's the telencephalon, here's some ventricles forming. So obviously, you know, your brain didn't always look the way it looks now, but this is pretty cool that you can see that. I saw a picture earlier on the internet of, I'm not going to Google it here, but you guys can off screen if you want to. The reason why they do sonograms instead of MRIs for fetuses, and that's because MRIs typically allow you to see through fetuses, and if you do a coronal section of a fetal MRI, the fetus looks like a scary nightmare demon because you just slice it wrong and it looks weird. So if you want a chuckle, go look that up while I'm talking. All right, so female reproductive system. It's more complicated because it has more jobs. So male reproductive system is responsible for consistently producing these cool little flagellated cells that are capable of escaping via a series of ordered processes and hopefully making it into a reproductive tract of somebody else, but not a guarantee. Female reproductive system has to receive that, but then it also has to accommodate fertilization, provide a place for implantation of an embryo, and then if implantation occurs and the pregnancy is maintained, be a house for 9 months. And if you've ever been pregnant, you'll know that being a house is a complicated affair. It takes a lot out of you, literally and figuratively. So, additionally, hormonally and structurally, the female system is more cyclic, both on an acute time scale and a chronic time scale. However, I do want to mention before we move on too much from male reproduction that historically, people with penises and testes have been characterized as acyclical compared with female reproductive anatomy and physiology, and that's increasingly becoming obvious. It's not quite true. So, there are changes to hormone production, libido, secondary sex characteristics, and sexual behavior in folks with a penis and testes that happen both on shorter and longer time frames, as well as people with a uterus, ovaries, and a vulva. So just, you know, keep in mind, there are some generalizations that can be made, but if you scrutinize any of them too closely, the distinction starts to go away pretty fast. So take this with a grain of salt. All right, so we'll return briefly to sexual differentiation because it's so cool. Okay, so let's look at this time frame too. At 8 weeks of development, I know it's not especially visible here, because they've omitted the rest of the reproductive structures. But at 8 weeks, you have early versions of all the stuff you're going to have, but a lot of it's not functional yet. So that 8-week developmental mark and the nominal presence of all the organs is kind of a hot button issue in reproductive rights debates. But it's important to note that just because the stuff is present doesn't mean it works. It absolutely doesn't. But what this means is, even after that, you still don't pick a sexual trajectory until 2 weeks later. And again, that's based on the presence or absence of the SRY region, the sex determining region of the Y chromosome, and the presence or absence of testosterone and Mullerian inhibiting factor. Now, chromosomally or receptor wise, there's lots of possibility there. So you can have a combo, and that would result in an intersex individual, which is somewhere on the spectrum between ending up with this and ending up with this. And again, as I said last time, intersex people are about as common in the population as redheads or people who identify as Jewish, so a lot more common than you might think. So if there's no testosterone, the mesonephric ducts have no clue that they're supposed to stick around, so they mostly don't. The genital tubercle becomes the glands, but of the clitoris, not the penis. And the urogenital folds become labia minora, and the labioscrotal folds form the labia majora, which in neonatal and in postpubescent anatomy accounts for the difference in those structures, both anatomically and skin-wise. So the labia minora are typically thinner and have less hair, and the labia majora thicker and more hair. So without Mullerian inhibiting factor, the paramesonephric ducts develop into the oviduct / uterine tube, the uterus, and the vagina. All right, so here we have a sagittal section, and then here we have what you would see if you were giving a pelvic exam. So the internal genitalia are the ovaries, which are quite deep in there, the uterine tubes, the uterus, and the vagina. And then this is the ureter, or the urethra, excuse me, and the ureter is not visible. And then here we have the urinary bladder. The external genitalia are the clitoris, labia minora, and the labia majora. So the clitoris is anterior if you're standing up and superior if you're not. And it exists in this little vestibule area between the two labia minora, and then the labia majora are on the outside of it. If you look closely, you'll notice that from a pelvic exam position, the external urethral orifice is above the vaginal orifice, and the hymen, which in this case appears ruptured, gives way to the vaginal orifice. There is a stunning variation in hymen morphology, both prior to and after rupturing of the hymen. So it is not by any means a one-size-fits-all structure. It can look like a lot of different things. So there's a pretty good Netter's Anatomy Atlas illustration of that if you are curious. People characterize it as this like one thing that has a specific developmental and sexual history trajectory, and that's not true. All right. Primary sex organs, ovaries. Why? Well, they make the gamete. Secondary sex organs, anything else, including external genitalia. One of my pet peeves is when people talk about the vagina, but they mean the vulva. Obviously, the vagina is a muscular tube that is extremely elastic and conveys menstrual tissue and or an entire fetus. And the vulva, although also interesting, does not have anywhere near the same function. So make sure you are being anatomically correct while talking about it. Okay, ovary, super cool, super weird. Looks way different than a testis. So the ovary produces oocytes. That's how you pronounce it, not oocytes. You basically say the O twice. So there's like a little sort of diphthong-like pause if you're familiar with linguistics, but it's almost not noticeable. There is a tunica albuginea on the outside, just like the testes. So like most things, it's got a connective tissue capsule. The ovary is organized into a cortex and a medulla. So the cortex is the edge bits, and this is the area where the germ cells develop. The medulla has mostly arteries, veins, and what are called stromal cells, which are just kind of structural cells that make up the rest of the organ that's not follicles. So you'll hear me talk about the ovarian phases. This is what I mean. Every 28-ish day cycle, a handful of groups of cells called follicles begin to get bigger and increase in cell number. So it's important to note, a follicle is not the same thing as an oocyte. An oocyte is a single cell. A follicle is a group of cells. So follicles consist of the oocyte, whatever stage it's in, the granulosa cells surrounding it, and thecal cells, not fecal, but thecal, THECAL, around that. So follicle is more than one cell. So we've got primary, secondary, and then large vesicular, which these are annoying because they have so many stupid names. It can also be called mature or tertiary or Graafian. All of those mean the same thing. It's a follicle with a big vesicle that's about to ovulate. Typically, one ovulates per month, although that's not always true. More on that later. And then after that, it develops into a transient endocrine structure called the corpus luteum. That means yellow body. They do indeed look yellow. And then after that, involutes into a corpus albicans, which is mainly just collagen. So it's a scar. So by the time a female fetus is born, so congratulations, fetus, you're now a neonate, it no longer has oogonia. So spermatogonia are stem cells, oogonia are stem cells. In males, spermatogonia persist for the lifetime of the individual. So from birth through development to death. In females, that is not true. So that accounts for the reproductive window difference between males and females. So during embryonic development, oogonia are going to differentiate into primary oocytes after they multiply, and then that's how many eggs you have for your life. So primordial follicles are basically your lifetime supply of eggs, and they contain primary oocytes surrounded by thin squamous cells. So they're just waiting. So between birth and puberty, they just chill and wait. An egg or ovum is any stage from the time of the primary oocyte to fertilization. From puberty to menopause, a few of these develop a month. So that's what we mean when we say cohort. So typically, your ovaries take turns ovulating. So one will go 1 month and one the next month. What happens to the rest of the follicles that started developing but didn't finish? They just stop, and then they undergo autophagy and go away. They're called atretic follicles. So follicle stimulating hormone stimulates follicles. That's what it does. And that makes the follicular phase of the ovarian cycle initiate. So unlike spermatogenesis, we've got this weird process where from one cell comes one cell. So in spermatogenesis, we have one spermatogonium and then 2 spermatocytes and then 4 spermatids, and all 4 of those spermatids turn into a sperm as spermatozoa. So there's a 1-to-4 ratio. With eggs, it's 1-to-1. So that begs the question, what happens to the other 3 cells? They become waste cells called polar bodies. So they're little more than a nucleus, and they undergo autophagy and just disintegrate after meiosis. So you get a first polar body after meiosis 1, and then a second polar body after meiosis 2. Sometimes one or the other of those will undergo its own little mini meiosis, which is thought to be vestigial. But regardless, they just whoop disappear. So if you're wondering about the reason for that, if you're like, well, why would you waste a perfectly good ovum? That doesn't make any goddamn sense. You would be correct. Here's the deal though, and I'll show you this in a minute. The female bipedal pelvis, bipedal meaning walking around on 2 legs, is adapted for walking. It's not actually very well adapted for childbirth. So the bowl of the pelvis and the pelvic aperture is not that great. And the reason is we had to make evolutionary changes to our pelvis to support our body weight for a full-time bipedal lifestyle. So what that means is humans are not really designed for multiparity, which means we're not intended to or very well evolved to carry multiple fetuses at once. Is it possible? Sure. Is it survivable? With modern technology and medical intervention. But it used to be that twins were super duper rare because, well, most people died giving birth to them. We're not really supposed to carry litters, much less 2 babies at once, because our pelvises just are not very good for that. And so what it's thought is that as those evolutionary changes occurred, going more towards bipedalism, pelvic apertures get narrower. There was also selection for less and less ovulation per cycle to minimize the chance of multiparity, because the uterus is just not really prepared to handle that. So if we look, I'll show you. So this is the real estate available for babiness. It's not very big. And the hole that it goes through, definitely not very big. Okay, so there's a question in the chat, and that is, when there are 2 eggs that get fertilized, is that 2 sets of eggs, or is one of the polar bodies fertile? It's 2 sets of eggs. So usually the ovaries take turns. So one will pitch 1 month and then the other the next month. But every now and then both go during the same month, or one throws 2 eggs. Does happen. The process is not perfect and it doesn't happen exactly the same way every time. So, interestingly, that means that if a sexual intercourse happens during the time when those 2 eggs are available to be fertilized, and both of them get fertilized, then you can get multiparous pregnancies, so twins or triplets or quadruplets. Potentially 2 fathers, yes, not unheard of. But for most human beings, not especially likely. And that's for the same reason why, like, you know, if you have like litters of dogs and cats, right? Because of the way their ovulations and fertilizations work, you can have like womb mates, let's say, that are half siblings. So that's borne out with animal pregnancies frequently. And we are capable of that as well. It's just that due to human sexual behavior, it's not especially common. Okay, so primordial follicles. These live in a little area of the ovary called, adorably, the egg nest, which is the name for the staging area where all the primordial follicles kind of just hang out. So they're sitting in the ovary surrounded by stromal cells, just kind of waiting. The granulosa cells form a initially squamous and later cuboidal layer around the primary oocyte. So they go from primordial to primary in response to FSH. So here's a primordial follicle. This, see how this is bigger and now these cells are cuboidal? This has transitioned over into being a primary follicle, but it's early called a unilaminar primary follicle. Now, this is also a primary follicle, but it's on its way to becoming a secondary follicle. So it's called a multilaminar or multi-layered primary follicle. And as you can see, here's the oocyte, here's its nucleus. The chromatin is busy doing meiosis stuff, so it looks chunky. No zona pellucida here, however, no thick pink layer. Here, there is one. So the zona pellucida is a glycoprotein layer, and this is integral to sperm binding and fertilization. It functions in two roles. One, it's weird. It's a double-edged sword. So on the one hand, it provides spermatozoa something to stick to. So if you look at microscopy images of in vitro fertilization occurring, you'll see lots and lots and lots of sperm all face first up against an egg. They are sticking to the zona pellucida in those pictures. They're trying to burrow through it, but it's a barrier to fertilization as well because the zona pellucida is thick and it's difficult to get through. So the sperm have to basically enzymatically degrade it to burrow through it, and that is a race. So whoever burrows through first is the successful spermatozoan. Congratulations to everybody here. We are all the winning one or a product of it. Everybody else that was competing with you at the time has perished. So congratulations on being the champion, my friends. We all are. So here's a fun fact. After that, yes, conception is absolutely a death match. Literally, if you win, you get to be born. And if you don't win and you're a sperm, you are out of luck unless there happens to be an additional ovum nearby. So we all won at great personal risk before we were sentient. Hooray us. Here's another cool thing. Polyspermy, which is the fertilization of one ovum with multiple sperm, this is really bad because that would create a triploid individual, and that is not a viable individual. So, you know, in like anime, when somebody like punches the ground and then everybody nearby flies off of the ground and away from the ground puncher. It's also very common in Kung Fu movies. The egg kind of does that. So it has these little granules associated with the zona pellucida, and the granules are essentially little packets of protein. And when the first sperm enters the egg sets off the granules and allows the granules to combine with water, which creates this rapidly polymerizing force field that repels, rapidly and catastrophically repels all the other sperm that are trying to gain access. So it's like a little series of sort of proteinaceous mucinous bombs in the zona pellucida that are triggered by the first fertilization, and it just basically, I mean, in the vernacular, it yeets all the sperm that were not the winner away from the ovum. And you can observe this in vitro as well. It's fascinating. It's very fast. So why is there only one sperm per egg? That's why. Okay. And I agree, at least we're not ovoviviparous sharks, because then we would have to battle our siblings in the womb and potentially be eaten, which would not be great. So that would be a race to be born first, so you can eat your brothers and sisters before y'all make it out. Yes, if you, that's true, although not with our mouths. That's the main difference. What you really absorb your twin, which is a slower and more insidious process. Sharks straight up launch them. All right, polycystic ovary syndrome. This is fairly common. PCOS is a common cause of infertility in people with ovaries. It also causes secondary sex characteristic and weight changes due to basically dysregulation of androgens. So you get ovaries with lots of cysts, and you do have attempts at follicular development, but lots of follicles don't complete maturation successfully, so they go atretic. But while they are doing that, they're also producing hormones. So you got hormonal issues, increased androgen production by the ovaries and or the adrenals is likely involved. Your adrenal glands produce androgens, and so do your ovaries. The ovaries produce something called androstenedione, and that's easily converted into testosterone and other androgens by various enzymes that are present. So polycystic ovary syndrome can be difficult to treat because the etiology for the reason for it existing is not well understood, and it varies from person to person as well. So it can be a frustrating syndrome to live with, because until you get a good endocrinologist, you're often kind of out of luck with regard to treatment, and it can be painful, very painful. Okay, what do I mean by cyst? Well, if you have polycystic ovary syndrome, that is actually a pathological outcome of a normal process. So you do have fluid-filled spaces in the ovary normally, but these are called antra. Antrum is singular, and these are fluid-filled vesicles or cavities. So we've got the oocyte still covered in zona pellucida, and then the cells around it are the corona radiata, and then there's the cumulus ophorus, which is this neck bit, and then the edge cells are the zona granulosa. So they're all the same kind of cell. So this is a granulosa cell, and so is this one. They're the same thing, but the words I just mentioned are the name for the shapes that they make, essentially. So like my A&P students have a really hard time with that idea. I guess what I would say about that is, for maximum understanding, is if I take two pieces of paper and I cut one into the shape of a bunny and I cut another one into the shape of a hammer, they're both still made out of paper. They're just different shapes of paper. So same with the granulosa cells. Same function, same material, different shape. All right, so this one is, I would call a secondary follicle, verging on a third. This one is slightly more developed and closer to a tertiary. The antrum contains fluid, which is a mixture of blood filtrate, which is plasma-like, but with less protein in it, and then also hormones as well, which bathe the ovum and help it develop. So, follicular cysts. You don't have to have polycystic ovary syndrome to have an ovarian cyst. In fact, most people with ovaries, whether they know it or not, have a ovarian cyst at one time or another. They vary in size and severity. They can go from unnoticeable to very, very painful. They can lead to menstrual irregularities, and if they rupture, you get this very intense pelvic pain out of nowhere, and then your pelvis fills up with fluid. Often blood enters that, which in many cases is a medical emergency, and you have to go to the hospital. They're not fun, I will say that. Okay. So, why are people's cycles different lengths? Why do you ovulate? What's the signal to ovulate? All of this is regulated by a complicated dance between the hypothalamus, the anterior pituitary, and the gonad. So, at puberty and every month between puberty and menopause, over the course of the month, you actually secrete GnRH in pulses. So it's not like the constant rate of secretion increases, but rather you go from having a pulse of GnRH every 2 hours during between times to 2 GnRH pulses every hour, so 48 per day, right before ovulation. So your hypothalamus is basically pulsing and pulsing and pulsing with gonadotropin releasing hormone. During that, the anterior pituitary is reacting by making FSH and LH. However, FSH is actually released, LH is saved up. So it's being synthesized, it's not being secreted yet. So during the early follicular phase, FSH is stimulating follicles to develop, and as the number of granulosa cells increases, so too does the number of estrogen molecules, and those end up circulating. So what keeps the GnRH and the anterior pituitary from getting out of control is inhibin, which is a protein that inhibits anterior pituitary and hypothalamic action and low levels of estrogen. So it's a combo package. And granulosa cells do that. Good question. So there's a question in the chat that was about the idea that women who are cohabitating will sync up their menstrual cycles. There were some early studies on that that looked at populations of women living together, and it was theorized to be pheromonal in nature, but it was anecdotal and observational and based on self-reporting, so the science wasn't especially robust. On the one hand, based on our ancestry and seasonal stuff, it would not surprise me if that was to some extent true. But on the other hand, I would need to see really compelling evidence with very, very tiny p-values to be fully convinced, right? So yeah, exactly. When the weatherman is usually wrong, you remember when it happens and don't when it doesn't. So that's another thing. There's a psychological phenomenology there, which is there's certain kinds of information that our brains really like to hang on to, and everything else is like, oh, that's not important, I forgot it. So I think there's a lot of things going on there. I could see arguments for or against, but like I said, I would need really, really good data to be fully convinced. Okay, so all this time, we've got a handful of follicles growing, and they're producing more and more estrogen. Meanwhile, luteinizing hormone is building up in the anterior pituitary, and then after a critical mass, essentially the estrogen rises to a level where instead of inhibiting, it enhances. So the inhibin goes away, the estrogen is left behind, and there's a lot of it. And that is excitatory to the hypothalamus and anterior pituitary. So that happens after about day 10, and that produces a phenomenon called the luteinizing hormone surge, or LH surge. That event causes ovulation. So you know how you can go to the store and you can buy a pregnancy test that tests for human chorionic gonadotropin, which is the first little, it's the first communication between an embryo and its parent, actually. It's the embryo being like, yo, I'm here, please don't menstruate. You can also get an ovulation test. And ovulation tests are also ELISAs, enzyme-linked immunoassays, but they are primarily testing for ovulatory products, and or in some cases, they'll also test for luteinizing hormone. But there's a much easier and more old-fashioned way to test for ovulation, and that's to take your temperature every single day because you experience a basal metabolic rate change round about the time of ovulation. So you don't need an enzyme-linked immunoassay necessarily. Okay, and then this is where I'll end, I think, for tonight because we're getting on in time, but we're making good progress. I think we're going to finish everything we need to finish. What I will finally say is, if you have ovaries, I do, some of us can feel the moment of ovulation. Not everybody can, but some of us can. And the name for that is a fun German word called Mittelschmerz, which means middle hurt. I'm trying to find the picture I was thinking of. There it is. Let me zoom in on this guy. So typically exocrine secretion, we think of some kind of goop being neatly deposited into a tube, and then the tube carries it out, and it's relatively painless. After all, it doesn't hurt when you sweat. Ovulation is a violent affair. So the ovulated oocyte and its attendant granulosa cells punch a hole in the wall of the ovary and jailbreak out of the side. They are not deposited into a duct that's carried to the oviduct. They jailbreak out of the side of the ovary into the pelvic void, and then hopefully blood flow and cilia, which are activated by the parasympathetic nervous system around about the time of ovulation, draw the ovum into the oviduct. But it's a bloody affair. It does bleed. It creates a thing called the corpus hemorrhagicum, which is right before the corpus luteum. And a lot of people can actually feel that occurring. So what it looks like is you're just minding your own business, doing human stuff, and then you're like, ow, dang. And it's unilateral typically, because usually it's only one side per thing. And then if you pay close attention, menstrual cycle happens several days later. So the name for that, and I'll spell it for you in the chat, it's a fun word, Mittelschmerz.